Welcome to Backfitpro headquarters. Thank you to everyone who responded to our question box on Instagram the other day. We received an overwhelming number of fabulous questions, which Professor McGill will be addressing in a series of short videos. We hope this way more of you can benefit from hearing his thoughts on commonly asked questions on the lumbar spine. We saw a few themes emerge amongst these questions, including exercise progressions, what you can do beyond practicing the McGill Big Three, stretching, and how to heal disc bulges. So let's proceed.
Well, before I start with specific answers, I need to establish some concepts. For years, I was being encouraged to write a book with the title, Fix Your Back in 5 Easy Steps to be a big seller. And I said, that's not possible. I cannot do it. So instead, I wrote Back Mechanic, which turned out to be 17 chapters. The reason is this: there's no such thing as non-specific back pain, just like there's no such thing as non-specific head pain or non-specific leg pain. Could you imagine someone giving an exercise for a person who says, can you give me an exercise progression for my non-specific leg pain? But here is the fly in the ointment. In the traditional medical system, there's no provision to get a thorough assessment for back pain. Instead, clinicians are paid to perform procedures, and a person going to see a clinician will receive the procedure that the clinician is being reimbursed for and has expertise in. Now, it may be a perfectly matched procedure, and you have good efficacy or good outcome. Or it might not make any difference, or it can even make the person's back pain worse. So in the absence of the ability to get a thorough assessment, we began our training program for master clinicians, which are listed on our website. But not everyone has an access to a master clinician. So the first part of Back Mechanic guides the reader through a self-assessment of their back pain. They look for patterns in the activities that cause their back pain and activities that don't cause their pain or even take it away. And then we get into specific tests to show if it's a certain position or a posture or a load or a movement that triggers the pain. And then it guides them through movement hacks to really address the cause and start to desensitize the pain and wind it down. And we're very aware of the psychological toll that back pain takes once it's occurred and the social toll on families. So this is a big issue, but it starts with understanding the mechanism of pain so we can wind down the whole process. But you see, it really requires specific cases to give examples of different subcategories of back pain to match the approach with the cause.
So we had a lot of questions about stretching, in particular hamstring stretches. What are your thoughts on this?
Hamstrings. Well, it's interesting that people with back pain quite often perceive tight hamstrings, and yet the assessment proves it's more dominant, the tightness of the sciatic nerve pathway, which goes down the leg within the hamstrings. So they say, I have tight muscles, I keep stretching my hamstrings. It feels good, and yet it never seems to break the cycle. Well, here's what goes on with most people with tight hamstrings. Stretching the hamstring muscle fires off the stretch reflex, which usually provides about 20 minutes of an analgesic effect, giving the false perception that they did something good, but underneath, stretching the nerve only made it more sensitive. So later on in the day, they have that need to stretch their hamstrings again. So as a little bit of an experiment, we suggest don't stretch your hamstrings, even though you have the urge, and instead practice some spine hygiene that addresses the cause of their tight hamstrings. And interestingly enough, quite often, the perception of the tight hamstring resolves. But the key was, what was the mechanism? And once again, we'll use pattern recognition. So with a younger person, the pattern tends to be more what we will call discogenic. In other words, a disc bulge impinges on a nerve root serving or creating the sciatic complex. So when they stretch the hamstring and pull the nerves down like that, they either get a friction or a pinch, giving the perception of tightness. And yet it was a non-flowing nerve up in the lumbar spine caused by a disc bulge. But that pattern changes as the person ages. It tends to be less of a disc bulge mechanism. The assessment will show that it's more often hypertrophied ligaments around the facet joints, which would be considered more of an arthritic category. Or this yellow ligament that you see here, the ligamentum flavum, starts to thicken up as we age, and particularly discs that have had prior trauma and they tend to be a bit flatter. Those are the facet joints that tend to grow fatter ligaments sooner. But yet again, there are various techniques, if we know the mechanism, that the person can employ and wind down their pain regardless of their age.
How do we know that these techniques are effective?
That's the million-dollar question. We started the experimental research clinic at the laboratory over 25 years ago now, and one of the mandates was that we will follow up with every patient that we ever see to know if we are effective or not. And there's very few clinics in the world that have done that, to know were they truly effective. So we would map what the person came in with in terms of pain reports. We recorded what the assessment showed their precise mechanism of pain was. We know what we advised them and coached them to do in terms of a starting program and a progression to follow. We know if they followed and complied with the program or fell off the wagon. And we know if they got better or not over the short term and over the long term. Was there permanency to the results? Now it matters how you ask that question of effectiveness, because you can really, from a survey kind of a study, really create the answer that you want. So we had to answer the efficacy, or ask the efficacy question many different ways. So let me frame it with an example this way. Let's take the category of a person who's been to the chiropractor, the physical therapist. They've gone through cognitive behavioral approaches. They've seen the surgeon for a surgery consult. All of those resulted in them not getting better. And they were told by default, we've tried everything. The last option you have is a surgical option. So if that's the category of person, and they were told the only thing that will work for you is surgery, I can now report that 95% of the people in that category avoided surgery and were glad that they did. Now, that's not to be interpreted that surgery isn't helpful. It's essential and absolutely helpful for certain types of back pain. But that's why I dedicated an entire chapter in Back Mechanic on that decision, to go through the algorithm and check the boxes to ensure that if you take the surgical route, check the boxes to make sure you have the highest chance of success, that that is the procedure for you.
We hope that this has helped some of you today, and we will see you in the next video.